directly testicle or is it paratesticular. Then percussion usually are not needed in this case. And then auscultate for bowel sound in the event of suspecting hernia with small bowel content. So what about other special tests? So these are just pictures demonstrating trans-elimination tests, but again it's negative in this patient. And then to complete your examination, you can also include palpation of the abdomen. In the case of suspecting a neoplasm, particularly the para-aortic region, palpate for any mass that would suggest it's a lymph node. So after physical examination, you must decide the direction of investigation. So with the differential diagnosis at the back of your mind, if you have already ruled out hydrocele, hernia, that left with malignancy or tuberculosis. So you can further divide your investigation into biochemical, imaging, or possibility of doing a biopsy. So for baseline investigation, it was normal. That includes your full blood count, your renal profile. And then for the tumor marker, alpha fetoprotein is within normal range. Same goes to beta HCG. So for ultrasound result, we have performed ultrasound for this patient. So the impression given was a right epididymal mass. Differential includes epididymal adeno-CA, fibroscrotal pseudotumor, less likely epididymitis. So due to the uncertainty of nature of swelling, surgery was planned to excise the lesion. The initial plan was for excision and also intra-op fresh frozen section, KIV orchidectomy. And the approach should be from inguinal rather than scrotal due to possibility of neoplasm. You don't want to cause any seedling. So these are the pictures taken intraoperatively. So here you can see that this part is the normal testis and the mass is arising from the paratesticular region. So once the op is complete, patient was seen later in a clinic during clinic appointment TCA. So wound inspection is done, is clean, no sign of surgical site infection. The HPE result is available, so we explain that to the patient. So for the HPE result, I would like to invite Dr. Naim from pathology department to talk about the HPE of this patient.
Okay, Assalamualaikum and good morning. I'm Dr. Naim Shahida from Department of Pathology. So I will be presenting the HPE findings for this patient. So this is the outline of my presentation. First, I will describe the macroscopic examination and then followed by the microscopic findings and also the differential diagnosis of paratesticular tumor from the pathological point of view. So this is the macroscopic examination. This is what we received. Basically, we received a right orchidectomy specimen. Consists of the spermatic cord measuring about 7 cm and also a testis measuring about 5 cm. And this is another view showing the testes, and also there is a tumor at the paratesticular area, and we can see this tumor is enveloping the epididymis. And this tumor, it has smooth multilobulated outer surface. So we take a few sections from this tumor and we examine under the microscope. And under the microscope, this is what we see. Basically, the tumor are composed of neoplastic cells and they are arranged in sheets. And they are also showing areas of hypercellular, characterized by this bluish color, and also hypocellular and ellipsoid areas, characterized by these whitish, bluish areas. And on higher magnification, we can see that these neoplastic cells, they display a pleomorphic spindle to ovoid hyperchromatic nuclei with occasional conspicuous nuclei. Besides that, we can see also there are abundant rhabdomyoplastic differentiation. So this is higher magnification of the rhabdomyoplastic differentiation. We can see this large polygonal to round cells with abundant pinkish cytoplasm. There are quite a lot here. So these all are the rhabdomyoblasts. In addition, we can also see cells that show occasional cytoplasmic cross striations or the strap cells. You can see here in this one cell, this is the pleomorphic nucleus, and this is the cytoplasm. We can see there are cross striations of the cytoplasm. So this is what we call as strap cells. And this is just to show the comparison. This is the normal skeletal muscle. You can see this is the nucleus, and this is the skeletal muscle cytoplasmic striations. So this tumor is trying to resemble the normal skeletal muscle features. Apart from that, we can see a lot of mitosis. In this one high power view, we can see already 5 mitosis. And we also proceed with immunohistochemistry tests. These tumors, they are positive for desmin diffusely and also MyoD1. So these two are the skeletal muscle differentiation markers. We also proceed with other markers, the SMA, CKAE1, AE3, and also S100. These three markers were negative. Basically, SMA is a smooth muscle markers. It's for leiomyoma or leiomyosarcoma. They are negative. The CKAE1, AE3 is a marker for epithelial tumors or carcinoma. It is also negative. And also S100 were also negative. S100 is a marker for neural tumors or tumors with melanocytic differentiation. So, based on the histological features of abundant rhabdomyoblastic differentiation, the features of strap cells, and also further supported by positive desmin and MyoD1, we conclude this tumor as paratesticular rhabdomyosarcoma, FNC LCC grade 3. So, just a bit about paratesticular rhabdomyosarcoma. Basically, it is a malignant tumor of mesenchymal origin that occur in the paratesticular tissue. It is rare and account less than 5% of all sarcomas. But if it occurs, most commonly it occurs in children with peak incidence at the age 4 to 6 years old, and also again can occur in adolescents. There are a few subtypes of rhabdomyosarcoma, which consists of embryonal alveolar, mixed embryonal alveolar, and also pleomorphic subtypes. And also they will stain positive for the skeletal muscle markers, which are desmin, MyoD1, myogenin, and myoglobin, and they will definitely stain negative for epithelial markers, which is CKAE1, AE3. So there are a few differential diagnoses for paratesticular swelling, but for this presentation, I will concentrate more on the paratesticular tumors. Basically, we can divide paratesticular tumors according to the differentiation, cell of differentiation. We can have mesothelial neoplasm, or the tumor can arise from epididymis, which giving rise to epididymal tumors. We can also have adipocytic tumors, the fat tumors, or smooth muscle tumors, skeletal muscle tumors, and also some other very rare tumors such as nerve sheath tumors, hemangiomas, nephroblastoma, and also paraganglioma. So I will briefly discuss the common tumor that may arise in the paratesticular area, which includes the adenomytoid tumor, cystadenoma, adenocarcinoma, And briefly about adipocytic tumors, smooth muscle tumors, and also skeletal muscle tumors. So let's go to the first one, adenomatoid tumor. Adenomatoid tumor, it is a benign tumor of mesothelial origin in the testicular anexa, and it is the most common neoplasm of paratesticular region, accounting about 33% of all tumors and also 60% of all benign tumors. It is most common in 4 decades of life. So this is a gross picture showing the tumor, the adenomatoid tumor with 10 firm cut surface. And microscopically, the tumor is composed of cells forming solid cords and nests with irregular tubules, and some may form glandular-like spaces. And next, we have of the epididymis. Actually, it is a benign papillary epithelial tumor of the epididymis. It is rare, but accounts for 1/3 of the primary epididymal tumors. The mean age is at 35 years old, but the range may include from 16 years old to 76 years old. So here we can see this cysts with intracystic papillary proliferation, some with cytoplasmic clearing. And next we have adenocarcinoma. It is rare, very rare in the paratesticular area, but I think it is worth to be mentioned. Basically, it is a malignant epithelial neoplasm arising within the epididymis. Again, very rare, with age range from 3rd to 9th decade of life. And patient may present with localized mass and often associated with hydrocele. Here we can see the tumor form villus and glandular structures, and some may have a clear cell appearance. And then we also have tumors with adipocytic differentiation. Basically, we have benign and malignant. The benign is lipoma, and the malignant is liposarcoma. For lipoma, it is a benign tumor, so it comprises of mature adipocytes of the paratesticular region, and most frequent in the 4th and 5th decades of life. So histologically, it will resemble the normal mature fat. However, if it turns malignant, it may appear as the spindle cells with pleomorphic features, and also we can also see some adipocytic differentiation. And we also have smooth muscle tumors, which include the benign, the leiomyoma, or the malignant leiomyosarcoma. So basically for leiomyoma, benign smooth muscle tumors that arise in the stomatic cord and testicular anexa. Again, it is rare, with the age range occurs from the 5th to 7th decades of life. Basically, the leiomyoma, it is usually a circumscribed lesion composed of interlacing fascicles or spindle smooth muscle cells. However, for the malignant counterpart, the leiomyosarcoma, it has more cellular atypia and composed of spindle cells arranged in fascicles and sometimes in herringbone pattern. And the last one, the skeletal muscle tumors. We have the benign skeletal muscle tumor, which is the rhabdomyoma, and also the malignant rhabdomyosarcoma. So for rhabdomyoma, it is the benign neoplasm composed of cells showing skeletal muscle differentiation. And it is very rare, most often affects young adults. And this is the rhabdomyoma. Composed of neoplastic cells displaying compact, large, polygonal, hypereosinophilic cells or pinkish cells. And from the rhabdomyosarcoma, it consists of primitive round to spindle cells. And then we can see also variable numbers of these pinkish eosinophilic rhabdomyoblasts, like what the patient had. So I think from the HPE part, that's all. Thank you.
Thank you, Dr. Naim. So after the HPE result, we arranged for a CT scan of this patient to rule out any distant metastasis. So from the CT scan performed, they show that there are no evidence of distal metastasis. So due to its rarity, we actually had a multidisciplinary meeting. We invited oncology as well as radiology on board as well to discuss on the imaging, just so we don't miss any metastasis. And from the oncology point of view, we discussed whether there are any possibility of giving adjuvant therapy. So without further ado, I would like to invite Dr. Hila to present a bit on the oncological management of case of paratesticular rhabdomyosarcoma.
Assalamualaikum and good morning. My name is Dr. Hilawati Yusof from the Oncology and Radiotherapy Department. So rhabdomyosarcoma is a rare disease. It is the most common soft tissue sarcoma in pediatrics, and it is extremely rare in adults. And the treatment is very protocolized based on the work by across the globe by a group in many groups in Europe, North America, and Canada. So this European CWS group has analyzed their data and grouped patients into favorable and unfavorable based on the prognostic factors. So in terms of pathology, embryonal being the favorable, alveolar being the unfavorable, and they also group the patients as according to post-surgical staging. According to completeness of the resection. So the group 1 has, in those patients that has had complete resection are not disease. Group 2, they either have microscopic residual disease, R1 resection of the primary, or if the primary is complete, but they have nodal involvement. Group 3, those patients who's had R2 or microscopic residual disease. So in terms of sites, favorable sites are orbits paratesticular. In our case, is considered favorable. Non-parameningeal head and neck, and the unfavorable all other sites, parameningeal extremities, bladder and prostate. So nodal involvement is unfavorable. Tumor size more than 5 centimeters is unfavorable, and the age 10 years or more is unfavorable. So this is a table by the RMS 2000 by this group, European Pediatric Soft Tissue Sarcoma Group, in their RMS 2005 study. So they have risk stratified the patients, divided them into risk groups. So the low risk, standard risk, high risk, and very high risk, and further divided them into subgroups from group A to group H as according to the prognostic factors, as you can see in the table here. And they studied the results for each subgroup from the different European studies. You can see here the CWS group studies, MMT, from as old as study in 79 until 96, and in the subgroup A, the low risk group, you can see the event-free survival rate is very high, around 90%. And as the higher the risk group, and you can see the survival rate become very poor, down to 25%. So in terms of adjuvant therapy, it is a multimodal treatment consisting of surgical resection, chemotherapy, and or radiation therapy. So a bit about chemotherapy. So the backbone regimen for most of the children is based on the combinations of these agents, so vincristine, actinomycin D, and cyclophosphamide, VAC, which is used in North America, or ifosfamide, vincristine, actinomycin D, IVA, which is used in Europe, and they both proven to be equally effective. How we dose the chemotherapy is based on the body surface area. So you can see the formula here. It is very individual based on patient's height and weight. So the agents we use is alkylating agent, either cyclophosphamide or ifosfamide. So these agents, they inhibit DNA and causing cell death. They highly toxic agents. They can cause severe myelosuppression, infectious complications, bladder toxicity, and neurotoxicity with ifosfamide in particular. So they also cause late side effects, include infertility and secondary cancers, namely leukemia. And because of this reason, the treatment has actually evolved over the years to omitting the alkylating agents in the low risk group, and also reduce the duration and dose of the alkylating agents in the standard risk group, and this has proven to not compromising the ability of the agents to prevent cancer recurrence. So the vincristine is vinca alkaloid. They mitotic inhibitors. Common side effects are peripheral neuropathy and constipation. The actinomycin D inhibits DNA transcription. They can cause myelosuppression, hair loss, and GI toxicities. So the actinomycin D is radiosensitizer. So when the patient's having radiotherapy, we will omit the actinomycin D. So based on our case, so he's 29-year-old engineer, married for a year with no children, presented with right testicular swelling, otherwise well in the past. So he underwent a right inguinal orchidectomy on the 15th of January, of which the HPA showing 7.5 centimeters, paratesticular, non-alveolar rhabdomyosarcoma. Resection margins were clear. So he underwent a CT staging scan on the 18th of February, which has shown no evidence of regional or distant metastasis. So if you look at the risk stratification, he falls into a standard risk subgroup B. So I will show in my next slides the chemotherapy cocktail that we're offering him, and there is no indication for radiotherapy. So he's currently undergoing a sperm banking and will start chemotherapy soon after. So this is the treatment summary based on the RMS 2005 trial. So the standard risk group will receive 9 cycles of chemotherapy over 25 weeks, which is given. So one cycle is every 3 weeks. So you can see here the alkylating agents, the ifosfamide, is only given for the first 4 cycles, whereas the vincristine and actinomycin D is given with each cycle for 9 cycles. So I'm putting this slide here just to show you the difference in the treatment in the very high risk group as well as the high risk group. So this showing the multi-modality approach we use. So the chemotherapy is still 9 cycles of chemotherapy over 25 weeks, and the difference is the alkylating agents is used, the ifosfamide is used with each cycle. So the operable tumors will be operated up front, followed by the chemotherapy, and then they will have interim assessment. So the first assessment will be after 3 cycles, and at this point, according to how they're responding, if they have partial or complete response, they will continue down the intended regime. And if they only have stable disease and the treatment has to be changed to a second-line treatment using a different agent, usually carboplatin-based treatment. And for the tumors that's still needing surgery, that will be offered after 4 cycles of chemotherapy, followed by radiotherapy from week 13 to week 19. And during the radiotherapy, the actinomycin D will be omitted. So they will finish all the 9 cycles around after 25 weeks of treatment. And at the end of the 25 weeks, in those patients that still have cross disease on the scan, further surgery will be offered. And this box here is showing a new treatment that has become a standard in Europe at least, which is a maintenance chemotherapy with vinorabine and cyclophosphamide. So this is actually following these trial results, which was published in 2019, RMS 2005, which has shown benefits in the disease-free survival and overall survival in the maintenance group. So the figures are 8 years survival benefit with the disease-free survival in the maintenance chemotherapy group, and about 12 years overall survival in the maintenance chemotherapy group. So this is how the maintenance chemotherapy is given. So this is again a lengthy treatment over 6 months, consisting of 6 cycles of chemotherapy, intravenous chemotherapy with vinorabine, which is given on day 1, day 8, and day 15, repeated every 28 days for 6 cycles, and the oral cyclophosphamide, which is given daily with no rest between cycles for 6 months. So a bit on radiotherapy in the for the paratesticular rhabdomyosarcoma. So it is only offered if there is question about the completeness of surgery, even in the unfavorable alveolar paratesticular cancers. So in case radiotherapy is necessary, the contralateral testicle should be positioned out of the treatment volume if possible. So I'm just showing here how our radiotherapy plan looks like. So this is from left mastoid rhabdomyosarcoma, patient treated 2 years ago. So as you can see here on the axial plane here, so the red bold line representing the target area and the green bold line representing the dose, the intended dose we're giving to the target volume. And as you can see here, the dose is highly conformal to the target volume on the axial slice, as well as on the coronal and sagittal slice. So this patient was treated with a special technique of radiotherapy called IMRT. So that's the end of my presentation. Thank you.
Thank you so much, Dr. Hila. It was a good presentation on the oncology side. So we continue on with the approach to scrotal mass. So this is according to the AAFP recommendation. So the broad heading of approaching any scrotal mass should be the first part of it should elicit whether it is a painful or is it a painless swelling. So if we follow the algorithm here, they have laid out quite clearly. So for non-painful scrotal swelling, during clinical examination, you can check for whether it transilluminates. If yes, then your diagnosis should be towards a hydrocele. If no, then you should elicit whether there are any bag of worms on palpation that increases with Valsalva maneuver. If yes, it confirms a varicocele. If no, then you should further to elicit whether it is a reducible mass. If it's reducible, most likely this is hernia. If no, Then you have to proceed to check if the testis is if the swelling is extratesticular and it's not tender. If it's yes, likely it's benign, but you need to do a further workup to confirm exactly what is that swelling. If no, you can do a Doppler ultrasound prior to a urology evaluation. If it turns out to be a unilateral mass, have to evaluate for testicular cancer, and then send off tumor marker as well, and also to look for any possible metastasis during this process. So in our patient, actually, it is extratesticular and it is non-tender. But of course, during the further workup, then it falls back into this group of turns out being a cancer. Whereas for the painful group, the first sign during examination should see whether it is a high riding or horizontal testicle associated with any nausea and vomiting. If yes, it has to be a presumed torsion, and then Doppler ultrasound can confirm this diagnosis. If no, have to look for any possibility of blue dot sign. If yes, if the blue dot sign is present, that means this is a torsion of testicular appendage. If no, then you have to proceed to see for any reduced blood flow on Doppler and then any raised inflammatory marker. If yes, again, this comes back to testicular torsion. If no, likely this is a form of epididymitis or orchitis, possibility of incarcerated inguinal hernia or hemorrhagic testicular cancer. So the take-home message from this presentation is that you should never discard or discount any painless swelling in a young male. So painless does not always equal to a benign cause. So you have to be aware of testicular tumor, the clinical presentation, especially after multiple GP consultation, and if it's adult onset and painless enlarging heart mass particularly. So in this patient, I think he went to 2 or 3 outside clinic, but he was told that no clinical examination being performed. Everyone just tell him this most likely hernia, I can write you a letter. But he was a bit unsure, so finally he went to another clinic in Cyberjaya. So clinical examination is very crucial. Do not assume it is benign until you actually examine it, and then referral to a urology is mandatory if in doubt. With that, I would like to conclude the presentation for today. Thank you.
Thank you very much, Dr. Gilbert, Dr. Naeem, and Dr. Hila for the excellent presentation. I think all of us would have learned a lot from how we approach a scrotal swelling, how we see the HPE, and how we treat the patient after surgery. So now the session is open for question and answer. Please feel free to type in your question either in the chat or in the Q&A group, and hopefully all the panelists here will be able to provide some answers or to answer the questions. We have Prof. Wong with us as well from the Department of Pathology. Yeah, so if you got any questions on the pathology, we can ask as well. Right, so feel free to type in your questions in the Q&A or the chat group. Maybe I'll start off with some questions first. Dr. Gilbert, may I ask, how do we examine the scrotum? Like, what is the best approach to examine the scrotum to differentiate all the different pathology that you were talking about earlier?
For standard clinical examination, of course, in the presence of a chaperone, if you're a female doctor, then get permission from the patient to expose and examine. You can do it in either a standing position or a lying down position. Both are acceptable in this case. So we start off always with inspection. Look carefully what you are dealing with, any skin changes, possibility of sinuses, discharges, and then prior to palpation, ask if patient is feeling any pain or any discomfort. Following by that, if you're suspecting of hernia during auscultation, you can also try to auscultate whether there's any presence of bowel sound, and then plus any special tests that you would like to elicit. If let's say you're thinking of hydrocele, you can switch off the light in the consultation room, and then you shine a torch and see whether it transilluminates. So if it's a tumor, usually it is very hard, very firm. Even you transilluminate, it will be a negative finding in that case. Then for inguinal hernia, usually you cannot get above the swelling. And once patient with a chronic history, if they are comfortable, they can reduce back the swelling, and then you can demonstrate by asking the patient to cough again. If lying down, some patient with a small orifice, they might not be able to exert this. You can ask them to stand up. So when they stand up, usually the mass will recur back, and this confirms your diagnosis of a hernia in that case.
All right, thank you, Dr. Gilbert. Probably.
Hi.
Okay. Yeah, Mr. Pham.
Yeah, Gilbert, just now in your presentation, maybe I missed it. I think you never mentioned about the tumor marker about this patient, right? Actually, just want to, you need to present to the audience that how is the tumor markers for this patient, and also the role of tumor markers in a testicular swelling, maybe.
Yeah, actually, it was in the slide, but I think because I only put 2 lines, but perhaps it was too fast. Just let me share back again for this patient. But it turns out to be normal in this case. I have it, I think, yeah, in this slide. So actually 2 or 3 lah. There are 3 common ones that we send off. It's always alpha fetoprotein, beta HCG, and also LDH.
Yeah.
But in this case, both of them turn out to be normal lah.
Yeah, I know. So if this is normal, so do you think this in the pre-op situation, do you think this might be most likely a benign situation, or usually if alpha or this tumor marker rate, it means what to the clinician?
Like I said, because the clinical presentation and also the examination is paired with the ultrasound result, is highly suspicious of tumor or neoplasm. So even in a normal tumor marker in this case, we shouldn't discard it. We shouldn't, rule out completely about malignancy. Because these tumor markers, they are designed to only pick up a certain type of neoplasm within the testis or testis region. So if it's a paratesticular swelling, sometimes this tumor marker would still be normal. So let's say for AFP, it is most common if let's say you're dealing with teratoma.
Okay, actually, basically, this is some knowledge to the medical student or our colleague is alpha fetoprotein tumor marker basically more on the germ cells testicular tumor, and the germ cell testicular tumor is it is the most common pathology for the testicular swelling, and but usually for germ cell and non-germ cell, one of the alpha fetoprotein or beta HCG will be raised. Even delta HCG and alpha fetoprotein is normal also, there will be about 15% of the incidence of seminomas as well. So it means if even you get a testicular mass with normal beta HCG, it didn't means we still need to further investigate for this patient, even up to orchidectomy actually.
All right, we have a question from the attendees. This is from Ms. Mashmin. Is there any role of frozen section biopsy during surgery?
Okay, in this situation, you see, we usually do a radical orchidectomy for a testicular mass. But however, when there is a mass that is esophagetic and also involve only very small part of the testis, which we will consider a partial excision of the tumor. Then, in that situation, we will need a frozen section to confirm the pathology. If the pathology is malignant, we will proceed with the radical orchidectomy. And if the tumor if the frozen section come back is a benign, then we will do some suturing part and repair the wound. Then we'll put back the testis. So for frozen section, basically we are talking about when we suspecting that tumor might be a benign esophagitic, and which we can partially excise the tumor.
I would like to ask the pathology, is it easy to differentiate between benign and malignant for frozen section in like this type of paratesticular testicular tumor?
Okay, from the pathology part, regarding the frozen section, basically if it's a benign lesion, inflammatory, we can see inflammatory cells with the neutrophils, with lymphocytes. For the neoplastic part, it depends on the type of tumor. Usually, if it's like in this case, it is a rhabdomyosarcoma, usually we can what spindle cell lesion, whether it is a rhabdomyosarcoma or is it a dedifferentiated liposarcoma, they can have similar features. So usually in frozen sections, we can't tell that. And then another rule of frozen section is for lymphoma. Usually we can tell whether those are neoplastic lymphoid cells or is it an epithelial tumor or a spindle cell lesion. And apart from that, we have to remember that frozen section also has a lot of frozen artifacts. So sometimes the interpretation is limited by those artifacts.
All right, there's another question from the attendees. Can hernia happen in ladies, women as well?
Let Ms. Lim answer.
Hernia can actually happen in female as well, but the thing is it's a bit rare. It's more common in male because testes actually descend from the abdomen to the scrotum, and during the descent, then they actually have the sac over there. That's why they make it more common in terms of male. But the thing is that it certainly can happen in female.
All right. There's another question. Is there any established environmental risk factors for cancer? Probably I'll invite Dr. Hila.
So to answer that is yes, and in this case, paratesticular cancer probably unknown. Or I'm just giving an example. What are the environmental risks? So we know about radiation. So radiation can cause cancer, although we use radiation to treat cancer. You know, we have background radiation, and the higher we go, for example, you know, flight travel, so that will put us at higher risk of cancer because of the radiation risk. And in terms of other things, so food we consume, for instance, salted food known to cause cancers of the nasopharyngeal tract, and things like cigarette smoking we know can cause lung cancer and also upper parts of the nasopharyngeal tract of the nasal oropharyngeal, and too much red meat can cause colorectal cancers. So there are environmental reasons for cancers, but in this case, then it's unknown.
All right. The next question is for the surgeons. Considering that the tumor is in a closed space and rhabdomyosarcomas usually we need a big surgical margin, would the scrotal skin be part of the tumor removal plan? That means we have to re-excise the scrotal skin now.
See, the testis is basically the different embryological origin from the scrotum, and they're having a different lymphatic drainage. So, and some more, the testis basically is not tightly adhered to the scrotum tissue. See, so if usually when we were going to do a scrotopectomy, when there is a scrotum violation, means that some surgeon they have doing some biopsy, maybe put some needles through the scrotum and or they have that ever doing orchidectomy from the scrotum, then end up the pathology come back is a malignancy, then we need to do a re-excision of the scrotum. So in this case, basically there is no infiltration, there's no tumor infiltration to the scrotum wall, and we are able to do an RO resection. Basically, there's no need for any further scrotum excision.
All right. There's no more questions in the Q&A or chat group.
I have a question to Dr. Naim. It's regarding reporting of the HPE. Can you always, or can you not always report what type of RMS is it? Is it alveolar, embryonal? How does the reporting works?
Okay, for this case, commonly for rhabdomyosarcoma in the paratesticular, most common is the embryonal rhabdomyosarcoma. And however, for rhabdomyosarcoma, if we want to say that it is embryonal rhabdomyosarcoma, we must also combine it with the molecular testing. So that's why in the report, because we don't do the molecular test, that's why in the report we don't specifically mention it is embryonal rhabdomyosarcoma. But the commonest rhabdomyosarcoma in the paratesticular is embryonal.
Thank you.
Okay.
All right. There's no more questions from the floor attendees as well in the chat group. I guess we have a very nice discussion and presentations on this topic. I hope everyone gets some nice information to take home today. So I'll pass the floor back to Prof. Dr. Zul to close the session, and then Bukhari will take over after that. Thank you.
Thank you, Mr. Koo. Yeah, I really agree with you. It's really an interesting session. And I hope like a lot of people having benefit from this morning discussion. There's also a take-home message from me actually, yeah. To all medical students and for those who are listening, I wish that you all please do not ignore painless testicular swelling. It is really, really important symptom because most of our patients tend to ignore, you see, and they tend to keep it for a long time. And the other one, we should promote self-testicular examination for men. Just like for ladies, they do self-breast examination, but for men, actually, self-testicular examination is really, really important. Again, saya nak ucapkan terima kasih pada semua panelis pada hari ini yang bersama-sama kita dalam CPC pada pagi ini. Saya juga ingin mengucapkan terima kasih kepada Sarawak Heart Center. Katanya ramai daripada Sarawak Heart Center yang bersama-sama dengan kita pada pagi ini. Terima kasih banyak pada semua yang hadir dan saya serahkan balik kepada Cik Bukhari lah untuk selanjutnya. Saya rasa ada Kahoot untuk medical student dan untuk scanning untuk PPD dan so well done again to all. Thank you very much. Terima kasih.
Okay, terima kasih Prof. Jadi saya akan sharekan untuk kita main Kahoot untuk medical student. So untuk medical student nanti gunakan nickname nombor matrix anda CPD point akan dikongsikan selepas Kahoot ini tamat. Thank you. Okey, barcode yang sebelah atas tu adalah untuk doktor sahaja. Ya, kena gunakan apps M&A. Barcode yang sebelah bawah tu untuk semua partisipan, untuk semua sekali partisipan. Barcode dan juga link tu adalah sama. Jadi untuk balas tu hanya sekali saja. Terima kasih. Okey, saya dah beritahu CPD point punya barcode tu ada masalah. Okey, saya akan semak sekejap. Sementara tu mungkin boleh isikan dulu maklum balas dispel. Okey, saya akan semak dulu yang CPD point punya barcode. Thanks.